Hello, my name is Ruth Mboro. I'm a graduate student at the University of Houston in the F&P track. So today I'm going to be presenting a case of a patient who comes to the clinic with signs and symptoms that direct us to diagnosing her disease as multiple sclerosis. We're going to be going through all the diagnostic criteria, the labs to look for. We'll also go through the pathophysiology of multiple sclerosis. We'll also go through treatment and patient education along with ongoing monitoring during treatment. I hope you enjoy. Here we have the presentation of the patient. The patient's chief complaint, in the patient's own words, is that my left foot is numb and I'm having trouble walking. History of present illness. This is a 24-year-old female who was in excellent health until 10 months ago when she developed progressive sensory loss in her right face, distorted hearing in the right ear, and intense vertigo. The symptoms intensified over 10 days, at which time she was hospitalized. A brain MRI showed an enhancing lesion in her right pons and a total of 6 other lesions, 3 of which are periventricular. CSF evaluation revealed elevated IgG index and oligoclonal bands. She presents to the clinic today indicating that she has had progressive left-sided sensory loss resulting in difficulty ambulating that began about a week ago when she had a mild URI and was experiencing increasing stress at work. Here I have highlighted some of the signs and symptoms that are pertinent to coming up with the diagnosis of MS. Past medical history includes chronic migraine headaches, which have been difficult to control with ibuprofen and sumatriptan, and depression that has not been treated. Family history. Both of her parents are alive and well. She has no siblings. She has no family history of neurologic disease. She is of Norwegian descent. She was born and raised in Wisconsin. Again, I have highlighted this part because MS is very common in Caucasians. Social history. The patient is single. She's also an accountant. She quit smoking 3 years ago, and before that, she smoked 1 pack per day. She drinks alcohol occasionally on the weekends. The only medication that she takes is ibuprofen 400 milligrams for her headaches, and she has no known drug allergies. Review of systems. The patient reports feeling run down and tired. She reports past difficulty with urinary incontinence and a feeling of weakness in hot weather. These two symptoms are very common with MS, especially as it progresses. Patients tend to lose bowel and bladder control, and also they tend to be very sensitive to hot weather. The patient has no previous history of visual disturbance or motor disturbance. The physical exam, the general. She is a Caucasian female who appears to be slightly anxious, but otherwise in no apparent distress. Here we have her vital signs and her BMI, which are non-remarkable. The skin has no lesions, tumors, or moles. Target is achieved in less than 3 seconds. Her HENT, parla, her extraocular movements are intact. Her tympanic membranes are intact. She has no icterus. Mouth and pharynx are pink and moist. The neck is supple with no lymphadenopathy or thyromegaly. Her lungs are clear to auscultation bilaterally. Her cardiovascular exam, regular rate and rhythm, no murmurs or extra heart sounds. Abdominal exam, bowel sounds are normal active in all 4 quadrants. Her abdomen is soft. Her genital and rectal exams were deferred. Her musculoskeletal, she has full range of motion in all 4 extremities, and she has 2+ pulses throughout. The physical exam continued. The neuro section is where we start to see a lot of remarkable findings. The patient is alert and oriented times 3. She has a mild subjective sense of auditory distortion and tinnitus in her right ear despite intact auditory acuity. Parla, she has visual acuity of 20/20 in both eyes. Her extraocular eye movements are full in extent, but she has slight nystagmus present. Nystagmus is highlighted here because it is a common finding in multiple sclerosis. Studies show about 70% of people with MS will have nystagmus. Motor tone and strength are normal throughout. Her deep tendon reflexes are hyperactive, which is a common finding in MS. The sensory exam reveals moderate decrease in the subjective intensity of light touch and pinprick on the left, with maximal deficits noted in the left foot. Again, MS usually causes sensory disturbances. Coordination testing is intact except for modest unsteadiness on performing tandem walking, and she has a positive Romberg maneuver. Those are signs of motor disturbances caused by MS. Here are the lab results provided for the patient. The other lab results that could have been done would be a CBC to check for any underlying infections, a HCG because she is a woman of childbearing age, and a vitamin D test to check for any deficiencies because deficiency of vitamin D has been shown to lead to MS progression. The diagnostic results that our patient presents with, the first one is a brain MRI, which shows multiple areas of increased periventricular white matter signal, also known as plaques. And the second one is that CSF evaluation revealed elevated IgG index and oligoclonal bands. Moving on to the diagnosis, the first diagnosis and the working diagnosis is multiple sclerosis. The second differential diagnosis would be Sjogren's syndrome. However, we were able to rule out this syndrome because some of the common signs and symptoms include dry eyes and dry mouth, which our patient does not present with. And also 70% of patients with Sjogren's have a positive ANA test, and our patient had a negative ANA test. The other differential diagnosis would be systemic lupus erythematosus, SLE in short. Now that we have gone through the case presentation of our patient and come up with the diagnosis of multiple sclerosis, let's move on to understanding what multiple sclerosis is. The pathophysiology of multiple sclerosis. Multiple sclerosis is a chronic inflammatory disease involving degeneration of CNS myelin, scarring or formation of plaque, and the loss of axons. Diffuse progressive disease affecting gray and white matter. The degenerative processes begin early and progress throughout the course of the disease. The etiology of MS is unknown. However, studies have shown that some of the precipitating factors include stress, viral infections, pregnancy, and genetics. The onset age of MS is between 20 and 40 years of age, with a peak age of 30. It occurs mostly in Caucasian females. If you remember, our patient is of Norwegian descent and she is 24 years old. The hallmark of MS is symptomatic episodes that occur months or years apart, affecting different anatomic locations. MS can be classified into 4 classes. The first class is relapsing remitting. Here, the symptoms of MS come and go. When the symptoms flare up, it's called an attack. These attacks can last for days to weeks and usually get better slowly. In between attacks, people often feel pretty good and normal, but some people have problems, signs, and symptoms that last even after an attack gets better. Relapsing remitting is the most common type of MS, affecting up to 80% of the population. The second class is secondary progressive. This class involves symptoms that come and go at first, but then begin to steadily get worse. This happens to many people who start out with relapsing remitting disease. The third is primary progressive. This means that the symptoms steadily get worse from the beginning. Progressive relapsing is when symptoms steadily get worse, and on top of that, there are also attacks that come and go. Some of the common signs and symptoms of MS are listed here on the left-hand side, and on the right-hand side, I have some of the symptoms that the patient was presenting with, just so we can compare and see that our patient is presenting with a lot of the signs and symptoms that we see with MS. Sensory symptoms in the limbs or one side of the face, visual disturbances, acute or subacute motor weakness, diplopia, gait disturbance, and balance problems, the Lemmet sign, which is shock-like sensations with neck flexion, vertigo, bowel and bladder dysfunction, limb ataxia, acute transverse myelitis, pain, and heat sensitivity. Diagnostic testing for MS includes an MRI, CSF analysis, and evoked potentials. MRIs in the case of MS will show demyelinated plaques. CSF analysis will show oligoclonal bands of IgG and an elevated IgG index. Evoked potentials will show slow nerve impulse conduction. On the right-hand side, I have the results of the diagnostic testing that was done on the patient, and you can see it matches the results that we expect to see in a patient with MS. Keep in mind, however, that there is not one single test that can be used to diagnose MS. Diagnosis of MS is very complex and involves good patient history taking and using this diagnostic test to confirm the diagnosis of multiple sclerosis. Treatment of MS. The goal of treatment is to prevent any disability, to improve quality of life, and to have the patient remain independent for as long as possible. Treatment is focused on symptom management. We are going to first treat any underlying infections, knowing that infection could be a trigger for an MS attack. For this particular patient, we are going to put her on a high dose prednisone because she is having an attack of MS. So the first thing is put her on prednisone 625 milligrams PO every day for a week. The prednisone can be prescribed as high as 1,250 milligrams. However, we start slow and go slow. We are also going to treat the patient's depression because it has not been treated, and depression is very common in MS patients. So we are going to put the patient on Cymbalta 30 milligrams, one tab every day for 4 weeks. MS can also be treated with immunomodulating agents. However, it is best to leave this to the neurologist because they require very careful and ongoing monitoring while using the immunomodulating agents. Ongoing monitoring for the patient. MS cannot be treated by one single specialist. It needs an interdisciplinary team. So therefore, we are going to refer the patient to a neurologist, an ophthalmologist, and a psychotherapist to begin with. The neurologist will be able to monitor the progression of the disease and any remission. The ophthalmologist will be able to treat any visual disturbances that the patient may have. The psychotherapist will be able to teach the patient new coping skills and how to manage stress. Physical therapy is also good for the MS patient and it's very helpful. It helps the patient to focus on ways to preserve or improve safety and independence with functional mobility. The patient is already having trouble walking, and we want to make sure that the patient can regain full function. An MRI will need to be done every 6 to 12 months to evaluate the progression of the disease. And I would have this patient return to the clinic in 4 to 6 weeks to evaluate the efficiency of the corticosteroids and the Cymbalta. I would also recommend support groups so that the patient will have people that she can talk to who are going through the same thing. Remember, MS is a progressing disease and the patient will have this diagnosis for the rest of her life. Patient education. Being that MS again is a progressive disease with no cure, we want to make sure that the patient is very well equipped with leading a healthy lifestyle that will minimize any future attacks. The patient will do that by living a healthy lifestyle, which includes a well balanced diet, daily exercise, and learning how to manage stress and to rest. We are also going to teach the patient to avoid contact with people who have any contagious diseases such as the flu, any colds, or any other infections. Teach the patient how to avoid hot or very cold weather as temperature can make signs worse and can also precipitate an MS attack. We're also going to involve the family in the care of the patient, or if the family is not available, involve those who were close to the patient. The patient needs a lot of emotional support and people who are going to nurture her emotionally so that she does not get into an MS attack through stress. And we also want to minimize the chances of the patient being depressed again. And we want to make sure that the patient has good emotional well being. The other area that we would focus on with patient education is immunizations because there has traditionally been a concern that immunizations would worsen MS by stimulating the immune system. However, there has been no convincing evidence that immunizations make MS patients worse. It is okay for MS patients to get immunizations. However, just like with any other patient, if you're sick, you don't get immunizations. So we would also teach the patient to not get immunizations while they're sick, wait until they get better to get their immunizations. But MS does not contraindicate immunizations. Thank you for your time, and I hope that this information was helpful to you and that you gained some new information on MS.